Hi, everyone. My name is Kimberly Lactalon. I'm a staff scientist at the University of Pennsylvania who has worked on projects from the Blanca-Himes lab and is currently in the Gary Wiseman lab. Today, my talk is on pre-processing electronic health records for analysis-ready data in an asthma cohort. EHR data captures extensive patient information for large-scale studies, and it can be greatly beneficial for representing real-life patient populations. However, it is complex, subject to inaccuracies, and prone to missingness, which may not represent a patient's true health status. The figure on your right shows how information such as test results and information from the care team is inputted in the EHR and back. However, how and what information is inputted is not always accurate, and interpreting the information can also be challenging. For today's talk, I will go over several specific challenges that I've come across in the EHR during exploratory analysis and data preparation. Using the tidyverse suite in R, I'll go over how I've cleaned and transformed variables using packages like dplyr, lubridate, stringr, and tidyr. At the end of this talk, I hope to leave you with examples that can also be applied to your research, or at least leave you with some challenges or limitations to be wary of when handling EHR data. As a caveat, my work uses EHR data that is gathered from the Clarity database from PennChart, which uses Epic, and so this data may not exactly be formatted the same way as other EHR databases. Also, we only have EHR data relevant to asthma research. However, much of this can be applied to other EHR-based research studies. Broadly, we have demographic characteristics, certain diagnosis codes, medications, and laboratory test results. And today I'll be going over some of the challenges I've come across from these variables. The first example is understanding how data was collected. In this data set, demographic information is presented at an encounter level. In the example figure, there are 4 patients in which patient 1 has had 3 encounters, denoted by encounter ID KDL1, KDL3, and KDL4. When creating table 1 of patient demographics, most of the time it made sense to use the most recent entry, not knowing, however, that some of this encounter level information already represented the most recent entry because it was pulled from the patient table rather than the encounter itself. And so I found out that demographics like sex, race, ethnicity, and smoking status were data that would be constant over time across encounters, and that variables such as insurance and BMI were unique to the encounter and therefore can change over time. This logically makes sense, but knowing how the data was collected would reduce the exploratory analysis and scripting stages. And so here I highlight the importance of understanding how the data is collected. And so your script can go from doing a bunch of exploratory analysis, as you can see on the left, to right off the bat, coding for the most recent entry of demographic information. Where on the right, you see that I used the asDate function from lubridate and filtered for the most recent entry of some demographics. Another challenge found from cleaning demographic data is finding conflicting patient information. I noticed that the race variables had values like white, Black, and Asian, but also had Hispanic, Latino, Black, or Hispanic, Latino, white options. So there was some overlap between the race and ethnicity variables. I first wanted distinct race and ethnicity variables, so I sought to change the HLB or HLW values as Black or white respectively, as long as their ethnicity category denoted Hispanic, Latino. However, I found out this was not always the case. For example, patient 5 had Hispanic, Latino, Black in their race category, but also non-Hispanic, Latino in their ethnicity category. To account for this conflicting information, I recoded race and ethnicity values when appropriate. This was done using the case1 function from dplyr. For patients that had race and ethnicity conflicting information, which I identified in this race ethnicity conflict data frame, I recoded the race and ethnicity values to unknown. For patients with no conflicts and that race had either an HLW or HLB value and the ethnicity column had Hispanic or Latino, which are patients within these data frames, I recoded race from HLB to Black and HLW to white. Another challenge I have found is that diagnostic code descriptions are not always consistent with its diagnostic code. And this could be important when wanting to group people based on their diagnostic code or their descriptions. For example, in the figure, it shows that there are 3 different types of descriptions for ICD-10 code J45.2. To have consistent diagnostic code descriptions, I joined diagnostic code information directly from the Center for Medicare and Medicaid Services, which contains the entire ICD-10 codes and their descriptions. Here, I read the diagnosis file and changed the format of the codes the same way as it's read in the ICD code file by removing all periods using the string replace all function from stringr. I then read the ICD file and created a table with ICD code and ICD definition variables using other stringr functions. The ICD code column was created by the second word from each line using the str split, and the ICD definition column was created by extracting text starting from the 78th character using str sub. When you see this file, if you ever look at this file, you'll understand why I had to format this table so that way I could join it together with the diagnosis file from the EHR. So when the formatting was correct on both data frames, I then was able to join the diagnosis file with the ICD file using left join, using the ICD code variable. All right, I mentioned before that this information may be helpful by grouping people, and this can be easier by transforming the data by patient, where we use pivot wider from the tidyr package, where you can see that there is a binary value for each ICD code on the bottom right of your screen for whether the patient had a presence of an ICD code within their electronic health record. Another challenge, more so time-consuming obstacle we have had to overcome is selecting for medications relevant to asthma treatment. We search for therapeutic categories and pharmacological classes like respiratory agents and corticosteroids, and narrowed our search to simple generic medications like inhaled corticosteroids, which are commonly used medications to treat asthma. However, not all specific medication names under these categories were likely to treat asthma. For example, the figure on the right shows a list of ICS medications, in which the second name is for the treatment of allergies. So to make sure we accounted for medications appropriate for the treatment of asthma, we worked with asthma specialists to individually select which asthmas we were to keep for further analysis. To do this, we first had an Excel file of all the medication names and looked at each medication name individually and had a keep column to determine if we were to keep them or not. You can see in this example, there's a screenshot of some of the biologic names and that there's a sheet in this Excel file for each type of medication. On the right, we read each sheet to create one data frame of medications using this map DFR function from the per package. This data frame or table was then used to filter for relevant asthma medications. In this last example, I wanted to provide an example from laboratory test results. In this case, eosinophil data, as it has been reported as a biomarker for severe eosinophilic asthma. The eosinophil data from the EHR has varying units of measurement, as you can see in the figure from this section of the script. Here we convert the units of measure to 1 unit for consistency using case 1 as what we've done before. In addition, this is not shown, but we also found instances where some eosinophil data did not report any units of measure. And so this is actually an example of an issue we are currently working on. We can remove the data, make our best assumptions, and possibly do chart review on the missing data where maybe the units of measure is available in unstructured data. In conclusion, I covered several examples where using EHR data for research studies has its challenges and how I've used R to prepare the data for analysis. I think the key takeaways from each example from this talk is to, as simple as it may sound, understand how the data was collected, as it can reduce the exploratory analysis and scripting stages. Be on the lookout for conflicting information, as it may not truly represent a patient's information. Be aware of unspecified information. Remember to collaborate with experts. In this case, asthma specialists would know what medications are used to treat asthma. And finally, simplify data when you can from the eosinophil example and really some of the other examples I went over today. I'd like to thank Blanca Himes and Gary Wiseman for their guidance, and also the Wiseman Lab members. And here is a QR code to this presentation slide deck and my email. Thanks everyone for listening. Hello. I think I'm the first person who had the chat open for this session or for today's talks. I see here, do you use any R packages for data cleaning of medications? Yes, oh, I guess when you talk about like specific, no, not really. Like if there's any like asthma related one, not that I know of. If that's the question you're wondering, because I know that there's some packages that people have created for like specific types of diseases.
So thank you and yay, chat, finally chat. I'm curious to know, I missed the very beginning of your talk, so I was in the other session. Can you talk a little bit about the skills that you would recommend somebody brings to this? So if a young clinical investigator wants to do things like what you did, where do they start?
Um, Loading the data, which actually could be a very long time to actually
Yep.
learn how the data is formatted, because it did take maybe probably a couple months talking with the data analyst who like captures the data from Clarity, and making sure that the format is correct, because even then like some things were shifted, so we would have to go back and forth being like, why why is there commas when there shouldn't be, or like I don't know. um, so that's a big step that could take a couple months.
Cool. Very cool presentation. Unfortunately, we are out of time, and so I'm going to bounce to the next session. Thank you. It was a lovely presentation.
Thank you so much.